Okay, I think the main point is that we pay a lot of attention to getting the system right for healthcare, but actually we also need to pay a lot of attention to what happens within each consultation and to think about how the burden of healthcare has changed, and have we altered training, have we altered systems of healthcare sufficiently to accommodate that change. So if we think about 150 years ago, you died of trauma, injuries, or you died of infections, or you died associated with childbirth. If you fast forward to today, you die of heart disease, lung disease, diabetes, cerebrovascular disease. So you die of strokes, lung disease, and heart attacks, diabetes. But in fact, those are the diseases which kill you, but if you look at the diseases which people live with for many years, the list is slightly different, and that includes many diseases like dementia or hearing problems or major depressive illness, or some long-term diseases like asthma, diabetes and COPD. And the key point is that these diseases, which people would live with for 20 or 30 years, need a totally different approach from that which you might use for an acute infective illness. So if I give you an example of that, if you were acutely ill and you rush along to your doctors and you say to the receptionist, "Can I see the doctor?" they might say, "Okay, I'm sure the doctor will see you as an extra patient." And under those circumstances, you might not be too upset if you had to wait half an hour to see the doctor. If, on the other hand, you've got a long-term condition which you've had for 20 or 30 years and you're having to go back for review by the doctor 3 or 4 times a year, and every time you go he keeps you waiting for an hour or an hour and a half, that is not good care. And so I think we all understand how the burden of healthcare has changed, but I don't think we've changed the training of potential healthcare professionals to accommodate that. And that training involves really treating patients in a different way, trying to support them as they self-manage their own condition, trying to help patients get involved in the decision-making about what treatment they're going to take every day. So it's not that I'm taking this morning and night for the next 30 years because the doctor told me to. I took part in that decision and understand why I'm doing it. And so we need to switch the whole emphasis round to what's important to the patient, not what's important for the patient. And that's what motivational interviewing is all about. So it's about working out, what is it you want from me? Well, I'd like a cure. Well, I'm sorry, we can't give you a cure, but we can give you safe and effective treatments which will keep you well. Well, what do you really want to achieve? Well, what I'd really like to be able to do is I'd like to be able to play football with my grandson again. Or I'd really like to be able to go out, and I used to enjoy doing the gardening and I can't do that anymore. So you switch it around to reach the patient's goals. You alter the consultation away in a way that you also try and say, well, if you want to go gardening again, you might find, and instead of saying you shall do this or you shall do that, you might say, you might find that if you walked to the end of the road every day for the next 3 weeks, at the end of that time, you might find you can walk as far as the park or the recreation ground. So everything is switched around to try and achieve the patient's goals. And it's that sort of change in our approach which I think we have not got through to healthcare to the present time. So we need to start thinking about new ways of training, new ways of selecting the sort of people who come into medicine, and new ways of working out how much is done by the doctor and how much is done by somebody else in the team. So if you go down to a motor car factory, the same person does not put the engine in as puts the wheels on and paints it. You have a team to deliver that care. And that's how we should be delivering care to people with long-term conditions. And all too often, we haven't accommodated that team. We're still very doctor-centric and we're still very hospital-centric, whereas actually you could take the team, so the most appropriate health professional at the most appropriate time, in the most appropriate setting, delivers that care to that person. Well, I think I should give some context to that, in that Imperial College was asked by the Singapore government to go to Singapore and partner a university there, Nanyang Technological University, and to deliver the imperial curriculum contextualized for Singapore with NTU in Singapore. But once I got there, it became clear that that was a missed opportunity, because actually delivering a new form of medical education in an established medical school is quite difficult, because you've got to decide which year will make the change. Do we teach two different curriculums for 2 or 3 years? How do we upset one group of people because you're no longer going to teach their subject, or you're not going to do it in that way? But given a blank sheet to start an absolutely new medical school, it enables you to stand back and think about, well, what could we do differently here which might be better? And so after we'd played around for about 6 months thinking that we were going to deliver the imperial curriculum, we totally switched the way we were going to do it. So very early patient contact was there. Most people who want to become doctors do so because they're excited by the thought about dealing with patients and helping people and understanding their diseases. They don't actually want to go and sit in a laboratory looking down a microscope for the first 2 years. So there was very early patient contact. The second underlying tenet was that we did not want to burden busy doctors having to teach if there were alternative ways of doing it. And so for a lot of the teaching of how you examine a patient, a lot of teaching about how you communicate with patients was done by a very small number of paid doctors who weren't doing it as well as trying to look after patients or as well as operating and that sort of thing. And most of that normal training was done actually in the community, not in hospitals with very ill patients. So most of the understanding of how the normal body works, how you should approach the normal person, what a normal heart sounds like, most of that was done in the community, not as is traditionally done in very ill patients in hospital. So there were a number of changes like that. And the other change was, of course, we realised that nowadays everybody is walking around with their phones and they're looking up facts and communicating in that way. And so we realised that actually the traditional method of learning lots and lots and lots and lots of facts and then regurgitating them in an examination and then forgetting it actually is not the way we need to do it. What you need to do is to be aware and know some basic facts, but you need to just be aware that something can happen. We need to be aware, for example, that two medicines given together might interact. But do you learn a long list of the ones that might interact, or do you learn that they can interact, and every time you want to do one, you check it quickly by looking up on your smartphone? So there was a whole change away from rote learning of large amounts of knowledge to most of the focus being on solving problems, and then recognizing that actually you have to have perhaps more structured exposure to some illnesses than happens at the present time. If you look at most medical schools, you will go through 5 or 6 years and probably everybody's seen somebody with a heart attack, probably everybody's seen patients with diabetes, but quite a few people might never have seen somebody with a collapsed lung, or they might never have seen somebody who's psychotic, somebody who's very, angry and aggressive. And it's quite unfair to expect those people then, as junior doctors, to handle for the first time something they've never seen before. And of course, the obvious analogy is that if you're an airline pilot, you don't suddenly experience all your engines failing at once for the first time when you've got 500 people on a plane over the Pacific Ocean. You have practiced that before in simulation. And so one of the other things was to massively incorporate simulation so that you could actually practice. So you have some actors, for example, and you might do a consultation with an actor, and then you view the actor going out afterwards, and, for example, they might do something terrible, like stab somebody at a bus stop. And you then replay the recording of that consultation and see where did you miss the clue that that was likely to happen later on. So you can look at whole courses of disease over relatively short periods of time and replay them and learn them by using that sort of simulation. It's quite difficult to disentangle why people want to do it. And I do think in selecting future doctors, we need to be quite sure that there is realism about why they want to do it. And sadly, sometimes there is a drive. Parents are very proud if their child becomes a doctor, as you should be. It's something to be proud of, but that shouldn't be the main driver. And we sometimes see people doing it because they're trying to please their grandmother or trying to please somebody else. And that can lead to people who are not happy in medicine as a profession. It can lead to people who don't necessarily have quite the right attributes to be a doctor. So I think we need to put much more work into a transparent process of selecting the right people and making sure that wherever possible, people are much more realistic about what being a doctor is like. And sometimes people, you ask potential medical students and they say, oh, it's a very hard. There's lots of jobs which are hard, and I don't think we should think medicine's particularly any harder than any other one. And what's important is to pick people with the right attributes, who bring the right skills, the right empathy, the willingness and ability to work as a team player, to listen, to be able to take constructive criticism. And to remain very flexible about what they're going to come across in their career. Because over 30 or 40 years, I've seen whole new diseases which I knew nothing about, was never taught about when I was a medical student. So you have to be a lifelong learner, and you have to be inquisitive. If I look at my grandchildren, they are avid for information. They're always listening. Why does that happen? How does that happen? And yet our educational system often knocks that out of people, that by the time they come to go through medical school, they say, what's going to be in the exam? What's the question? And that's their approach, instead of being inquisitive. And we won't get good scientists to solve the world's problems if we don't have inquisitive doctors.